All right. Today we're explaining the anatomy and the orthopedics. Both of them are a very long topic, we need to carry on quickly and get a very broad idea on the anatomy and the orthopedics and what comes in the exam, basically. So the first things, again, like every time we do, we're giving you the high yield topics. We're not explaining all the anatomy. We're not explaining all the orthopedics, but it's basically the high yield topics and points that usually come in the exam. So here, first thing is something called the vertebral levels. This is actually a very common question. To be honest, not all of them are very important, but they come in MCQ. Okay, they always come in MCQ, but I would say not all of them. So we're giving you all the levels with all the common structure that passes at that level. But in my opinion, the most important one is the L1. L1 is very important, and I would say as well C6 is important as well, and finally L4. And yeah, I mean, this is pretty much it, the important levels. However, you need to go through all the things. So obviously at C3, we have the hyoid bone. And at C4, there is the bifurcation of the common carotid artery. So common carotid artery comes from the arch and then goes a little bit up. And at C4, it divides into internal carotid artery and external carotid artery, and the thoracocartilage, which is at this area, just at the Adam's apple area, is the C4 level. At C6, there is a cricoid cartilage. The trachea begins at this area, and the esophagus begins at this area. So it's basically cricoid cartilage and the beginning of the two tubes that you have in this area, which are the trachea and the esophagus. At T1 level, there is the sternoclavicular joint. At the T1 level, obviously, I think that you all know that. At T2 level, you have the superior angle of the scapula and the suprasternal notch. This is at T2 level. So obviously, you have the T2 at the back, and there is T1. So at the T1, there is a sternoclavicular joint, which meets it on the other side of the chest. So anteriorly, you have the sternoclavicular joint at the level of the T1. And then below that, you have the superior angle of the scapula and the suprasternal notch in this area as well. T4, it's called plane of Ludwig. T4 is actually quite important as well. So T4 is the arch. So let's say this is the T4 level. So the arch of the aorta starts and ends at T4 level. All right. So this is the arch, the aortic arch. So starts here and ends here, and this is at the T4 level. The trachea at the front will divide in this area into two main bronchi. So it's basically the bifurcation of the trachea, beginning and the end of the aortic arch. And this is the sternal angle from the front, which is at basically your second rib, right? This is the sternal angle. And this is also an imaginary line that divides between the superior and the inferior mediastinum, and also the astragus veins, which is coming from all the way down. You start to join the superior vena cava, obviously on the right side. Okay, so again, T4 level is quite important. So this is, if we're going to start it in a systematic way, it's an imaginary line that divides the superior mediastinum between the inferior mediastinum, number one. Number two is the beginning and end of the aortic arch. Number three, the bifurcation of the trachea into the two main bronchi. And number four is the astragus vein comes from this side and joins the superior vena cava. And finally, this is the sternal angle of fluid. It's at this level from the front. Okay, so at T8 level, so actually this is quite important as well. So T8, T10, and T12. T8, T10, and T12. So you have inferior vena cava at T8, and number two is esophagus at T10, and the aorta is at T12. Okay, the aorta is at T12. So it's from the back to the front. So the aorta first, and then the esophagus is a little bit higher, and then the inferior vena cava is the highest point of the diaphragm. Because I mean, your diaphragm is not very flat, it's going this way. So it's going from the front to the back. So it's a little bit higher, and then to the back is start to go down. So from the end of this area of the diaphragm, there is an opening for the aorta at T12, and then the esophagus at T10, and then the inferior vena cava at T8. So this is actually very important. You need to remember it. And the way I always remember this is, so you have basically an esophagus between an artery and a vein. So esophagus between artery and a vein. So obviously the esophagus will be at T10, all right? So it's an esophagus between an artery and a vein. So which structure is more important? Is it the artery or the vein? Okay, so obviously both of them are very important, but the artery is more important than the vein. So our body tends to protect the artery more than the vein. So the artery is always in the back, protected with bone, protected with multiple organs all around it. So the artery would be on your end of your body, okay, from the back, okay? And it's protected by the vertebrae as well. So obviously the artery would be at 12. So this is the aorta is at 12, and the inferior vena cava is at 8, okay? Your transpyloric plane, think about everything in the abdomen, like literally everything in the abdomen, and it does have a structure passing at the level of a T9. So basically, it is called the Addison's plane or the transpyloric plane. Let's start with the bone. This is the 9th costal cartilage. From the stomach, you have the pylorus. From the gallbladder, you have the fundus. From the pancreas, you have the neck. From the spinal cord, you have the conus medullaris. You have the superior mesenteric artery arising at the lower level of T2, the lower level of T1, and the higher level or the upper level of T2. Okay, you have the hilum of the kidney, and you have the duodenal flexure. So the way I would do it, so you have here the stomach. So the fundus of the stomach is at this level, and then it goes all the way down, and then coming this way. So you have the duodenum as well. The duodenojejunal flexure, which is this part, the duodenojejunal flexure, will be at the same level. Obviously, my diagram needs to be a little bit, just like that. Okay, and then this one as well. So this is the level of T1. So you have the pylorus of the stomach, which is this area. Needs to be honest, it needs to go a little bit down. But anyways, just imagine it. And you have also so number 1, pylorus. Number 2 is the duodenojejunal flexure. Okay, and also from the lever, you have the 9th costal cartilage, which covers it, and you have the fundus of the gallbladder, and the pancreas passing here, which is the neck of pancreas passes at this level as well. And also you have the artery, which is the aorta here, the superior mesenteric artery at the lower border of L1, and from the kidney on the other side, you have the hilum of the kidney. So basically thinking about all the organs that pass in this area, okay? So this is the level of L1, and in my opinion, this is the most important level among all of them, all right? In L2, you have the renal veins, the thoracic duct begins, and azygos and hemiazygos vein begin. You just know it. And L3, the umbilicus is L3, and L4, you have the iliac crest. And this is very important for doing a lumbar puncture, okay? A lumbar puncture, because you do your lumbar puncture in L3, 4, okay? Between the L3 and L4. So you get the level of the ASIS, or the iliac crest, and you go all the way back, and this is the level of lumbar 4. Okay, so this is why it is important. L5 is the beginning of, and obviously L4 is an artery, so it's the bifurcation of the aorta, and L5 is a vein, which is the beginning of the inferior vena cava, and S1 is sacral promontory, and S2 is posterior superior iliac spine and dural saccans. So this page is not interesting, but it's very important. Okay, so you need to know that the T8 is the esophagus, the T10 is the esophagus, the T8 is the vein, the T10 is the aorta caetis. You need to know that L1 is called the Addisonian plane, and you have many unit structures passing in this area, which is the lower border of L1 in this area, the pylorus of the stomach, the duodenojejunal flexure, the neck of pancreas, the fundus of gallbladder, the hilum of the kidney, and the conus medullaris, superior mesenteric artery arises. So many things at this level. And also you need the T4 is basically an imaginary line, separates between superior mediastinum, inferior mediastinum, beginning and the end of the aortic arch, bifurcation of the trachea, and the azygous vein joins the inferior vein, the superior vena cava, all right? And so on and so forth, all right? So this is an important table. You need to know all the stuff now. So here quickly, we're not gonna go into detail of the upper limb anatomy, but basically we're explaining the common structures that comes in the exam. So here you have the thenar eminence. What is the thenar eminence? Okay, so the thenar eminence is basically this part of your hand is the thenar eminence, and this small part is called the hypothenar eminence. So this part, just at the base of your thumb, is the thenar eminence, and at the base of your little finger is your hypothenar eminence. Obviously, all of them here, which is at the base of the thumb, the thenar eminence, okay, will be muscles going to the thumb, which is the pollicis, all right? So pollicis. So you have number one, opponent's pollicis. This is this muscle that does this movement to the thumb is called opponent's pollicis, all right? And also you have abductor, pollicis longus, and the flexor pollicis longus brevis, sorry, abductor pollicis brevis, and the flexor pollicis brevis. Brevis means it's a small, the origin and the insertion from this area, but longus will be coming up from the elbow, all right? So you have three muscles in here that is called the thenar eminence, and all of them will be pollicis, and two of them will be brevis, and you have the flexor brevis, abductor brevis, opponent's pollicis, all right? These are the muscles of the, basically the thumb, which is called the thenar eminence. Hypothenar eminence, it's on the other side of your hand, and there are two muscles that supply the little finger, which is called the digiti minimi. Digiti minimi is your little finger. The minimal or the smallest digit is called your little finger. All right. So you have here flexor digiti minimi brevis, flexor digiti minimi brevis, and abductor digiti minimi. These are the hypothenar eminence. If you look at my hand here, you actually see a muscle moving, right? A muscle moving. This is the abductor digiti minimi, and here this is an flexor digiti minimi brevis. All right. So this is the hypothenar eminence. Your nerve supply is quite important as well, and we're going to discuss at the end of the session the nerve injury, which is a very important topic. All right. So your nerve supply, the sensation of the hand. So you have here, obviously this is your thumb, so that's lateral, and this is medial, and on the other side it is medial as well. I mean, you can imagine what I'm saying. And here, since you have a flexion here, so this is the palm, and on the other side this is your dorsum. Okay, so the sensations of the medial 1.5 finger, the sensation on the medial 1.5 from the palmar and dorsal surface are supplied by the ulnar nerve. 1.5 finger from the medial 1.5 finger, dorsal and palmar will be supplied by the ulnar nerve. Okay, so the medial nerve will take the lateral 3.5 fingers from the palmar surface. So if you can see here, the palmar surface, lateral 3.5 fingers, and just the distal area of these fingers on the dorsum. Okay, so this will be the median nerve, and the radial nerve will take the rest, basically the area of the anatomical snuff box. So basically it's this area. Okay, so this is the radial nerve distribution. So these are the sensations. Here, I think I explained this before last time in neurology, I believe. So the upper limb dermatomes, I said this is 5, so 5 goes here, 5 goes here, okay, and then continue. So 5, 6, and then it goes to the middle finger is 7, and then it's 8, and then it's 1, and then it's 2 in this area. Okay, so go again. 5 goes here. Where is 4? 4 is a little bit up on the deltoid. Where 3 is just right here. Where is 2 is just right here. Okay, so that's you, neck. So what are the nerve supplies? So we mentioned here the dermatomes. There is difference between what are the dermatomes and what are the sensation or the sensory nerve supply, because you need to know the peripheral nerve, but dermatomes is basically more central nerves, all right? So obviously above the over the deltoid area is C4, like we mentioned, and this is supplied by a nerve called supraclavicular nerve. Supraclavicular nerve, all right? And the T2 area is called intercostal nerve. At the T1 area, it's all this area from the medial side, is called the medial cutaneous nerve of the arm. And here is the medial cutaneous nerve of the forearm at the distal part. On the other side, lateral cutaneous nerve of the arm at a C6 level. And C5 is lateral cutaneous nerve of the arm. And here you have the upper lateral cutaneous nerve of the arm. Okay, so basically you have cutaneous nerves of the arm and the forearm. So when you're talking about the arm, this is the upper lateral cutaneous nerve of the arm from the axillary, and this is the lower lateral cutaneous nerve of the arm from the radial, and this is the lateral cutaneous nerve of the forearm from the musculocutaneous nerve. And on the other side, it is the medial cutaneous nerve of the forearm, and the medial cutaneous nerve of the arm, and then intercostal nerve and supraclavicular nerve, and the C4, the nerve distribution. So we mentioned the dermatomes and we explained them. You know, C4 is the deltoid area, C5 just below it, and then C6. C7 is the middle finger and its continuity in the middle, and C8, and then T1 and T2. So, I mean, in my distribution, I went to the T1 is slightly lower, which is correct as well. But I mean, it's still the same distribution. So C8 will take from the little finger all the way down to the middle of your forearm. And then from here is T1 to the middle of the arm. And then T2 is a little bit up towards your axilla. All right. So this is the nerve, the dermatomal distribution. You have here the carpal bones. We'll just mention them quickly. I would assume that all of you will know that. So you have the scaphoid right here, which is the important bone, is scaphoid, and then lunate, and then triquetrum, and then pisiform, small bone over it, and then trapezium, which is right here, trapezoid, and then capitate, and then hamate at the end. So these are the carpal bones. I assume that all of you know them already. So here, this is your knee, as you can see here, and this is your tibia, and this is your fibula. There is a common nerve that passes on the lateral neck of the fibula, and the lateral side of the neck of fibula is called common peroneal nerve. This is very important. The common peroneal nerve injury is very common with the neck of fibula fracture, and it will bring about some sensory and motor issues that we're going to talk about in orthopedics in the second part of our session. There is something called montagia fracture. This is the way I know it. So MUGR. So montagia fracture, and here in this scheme, we're talking about the fracture, not the dislocation. So you have something called montagia fracture and Galeazzi fracture. So montagia fracture, montagia means it is an ulnar fracture, and then superior radioulnar joint dislocation. So when you have an ulnar fracture and superior radioulnar joint dislocation, this is called montagia fracture. On the other side, Galeazzi fracture. So Galeazzi is a radial fracture, GR. So you have a radial fracture and inferior radioulnar joint dislocation. This is called Galeazzi fracture. So always know this scheme, MUGR. Montagia is ulnar fracture and superior radioulnar joint dislocation. All right. Galeazzi is a radial fracture and an inferior radioulnar joint dislocation, and your scheme is MAGR. All right. You have also the sensory nerve supply of the lower limb. So if you remember The dermatomes of the lower limb, we mentioned that outer are odds, so outer are odds and inner is even, right? What does it mean? So outer, so in the pocket area, just from the outer side would be an L1. The outer side of the thigh would be an L3. The outer side of the leg would be an L5. The outer side of the foot would be an S1, all right? And the inner is even, all right? So you can get the inner side of the thigh would be an L2. Inner side of the knee and leg will be an L4. And inner side of the foot would be an S2, all right? So this is how I remember it. It's not like absolutely correct, but most of the time, I mean, there is overlap between the areas. It's not like we're cutting it or something. So there is always overlap between the nerves, and you'll find many different diagrams for how it looks like. But this is the way I remember it, and it's very, very close to what the right answers. The outer odds and the inner are even. So what are the nerves then? What are the cutaneous innervation of this area? So remember, we mentioned the common, the lateral, the outer side or the lateral end of the neck of fibula, right? So the common peroneal nerve, it gives branches here, and then it gives a superficial branch, which is called, a superficial branch of the common peroneal nerve is right there as well. So we're basically here talking about the outer surface. So the common peroneal nerve supplies all the leg, basically. Okay, again, sural nerve, it takes the foot, and how do you remember it? Sural is lateral as well. So sural nerve is lateral, LA, so sural nerve is lateral. And the common peroneal nerve, you have superficial branch and deep branch. So the superficial branch, take the lower side of the lateral surface of the leg and all the dorsum of the foot, apart from the first rib space between the big toe and the second toe, it takes the deep branch of the common peroneal nerve. So again, the common peroneal nerve has two branches, superficial and deep, all right? So superficial and deep. The common peroneal nerve itself takes the lateral side of the knee, okay? Then it gives superficial branch, it takes the lower outer side of the leg, and then the dorsum of the foot. All the dorsum? No, it's not all the dorsum, apart from the first rib space, which is supplied by the deep branch of the common peroneal nerve. The saphenous nerve is on the other side. So basically on the other side of the leg, it will take all the other side on the medial side. The sural nerve, it ends with an AL, so lateral. Sural is lateral. So it takes the lateral surface of the foot. If you go a little bit up, obturator nerve is medial, lateral cutaneous nerve of the thigh is lateral, and then you have posterior cutaneous nerve of the thigh is obviously posterior, and then there is a femoral nerve, anterior cutaneous nerve of the thigh. This is in the anterior surface of your thigh. Okay. So again, sorry guys, I'll just stick with them. Hello. Yeah. Sorry, everybody. So again, we have the thigh and the new leg. So the thigh from the front, anterior cutaneous nerve of the thigh, from the lateral cutaneous nerve of the thigh, and from the posterior is the posterior cutaneous nerve of the thigh, and then from the medial side is the obturator nerve. And your leg, think about the common peroneal nerve, saphenous nerve, and sural nerve. Common peroneal nerve is starting from the lateral side of the neck of fibula, supply the lateral side of the knee and lateral side of the leg. Okay, not all the lateral side, because the lateral side, when you go a little bit down on the lateral side of the leg and the dorsum of the foot is the superficial branch of the common peroneal nerve, whereas the deep branch is in the first rib space between the big toe and the second toe. All right. Well, so the motor nerve supply, this is the myotomes. So here, guys, we're talking about something called dermatomes. All right, and here you're talking about the myotomes. So what is a myotome? That supplies the muscles. So basically you have the sciatic nerve, and the sciatic nerve, you all know that it is two branches. which is the common peroneal nerve, is one of them. One is called the tibial nerve, all right? So it's basically tibial and common peroneal nerve. And it divides at the upper border of the popliteal fossa, all right? So this is the just quick topics from the lower level. Again, we have here the biliary tree and how does it form. So number one, we're going to start with the pancreatic duct that has multiple drainage into the pancreas right there. And then pancreatic duct goes to ambulovator and then goes to the common bile duct as well. They join together all the way up. You have here the cystic duct, which is coming from the gallbladder that joins the common bile duct and then forms something called common hepatic duct and then divides into the liver into two distal ducts, which is right and left hepatic ducts. This is called the biliary tree. So the biliary tree is basically you have right and left hepatic ducts, go all the way down to common hepatic duct, and then this divides, or not divides, I mean, you have the cystic duct that join this one, which is coming from the gallbladder, and go all the way down. When this happens, it's called common bile duct. The common bile duct joins the pancreatic duct, and the pancreatic duct goes to the ambulovator and drain into the second part of the duodenum, right? So this is basically your biliary tree, okay? Well, so ambulovator is the hepatopancreatic ampulla and the second part of the duodenum. Remember that. This is where the celiac trunk stops and supplying the gut and the superior mesenteric artery. So here, this is, the opening of the ambulovator right here divides between the foregut and the midgut. So you have the gut is divided into number one, foregut, number two is midgut, and number three is hindgut, all right? And the foregut is supplied by the celiac trunk, and the midgut is supplied by superior mesenteric artery. The hindgut is supplied by inferior mesenteric artery. So this area divides between the foregut and the hindgut, and the ambulovator, the celiac trunk stops supplying the hindgut at the foregut at this area. Okay, cancer head of pancreas, second part. Okay. Well, if you have cancer head of pancreas, what will happen is it will close this opening, and it will lead to jaundice because obviously your bile is not draining, and it will cause a post-hepatic problem. All right, so it will lead to jaundice as well. Well, spleen. So your spleen is right there on the other side. Obviously, this is not your spleen, that's the liver, right, on the right side. And here is your spleen. What is the blood supply of spleen? So obviously, when you're being asked about the blood supply of anything, you obviously mention, so when you're being asked about the blood supply, you obviously mention number one, what is the arterial supply? Number two, what is the venous drainage? Okay. So now we're talking about the spleen. The spleen is considered as part of the foregut. So if we have the aorta right there, so you have a celiac trunk, which is at the upper border of L1 level. The celiac trunk will give a tortuous, big splenic artery, goes all the way into the spleen and passes behind the stomach. And in the stomach itself, we have something called the short gastric vessels. It also gives supply to the spleen, okay? So the arterial supply is basically coming from the splenic artery, which is coming from the celiac trunk of the aorta, which comes at the upper border of L1. Venous drainage is basically a splenic vein, and that splenic vein is tortuous as well, and just passes on the superior border of the pancreas, okay, and also takes venous drainage from the pancreas as well, and then it joins the superior mesenteric artery to form something called the portal vein, okay, something called the portal vein. This is why we always say like hepatosplenomegaly. You feel like it's the same word, but that's the main thing. If you have hepatomegaly, you're more likely to have a splenomegaly as well, okay? Because the venous drainage of both of them is the same. So the reps on the spleen is 11, 9, 10, and 11 is the reps on the spleen. And the structures to worry about during a splenectomy is basically the tail of pancreas, because the tail of pancreas ends in the hilum of the spleen. So it's a very common scenario. You have done a splenectomy for one of the patient, presented to you after that with very severe abdominal pain and basically very severe hyperglycemia. So what is that? It is you have injured the tail of pancreas for this patient during your splenectomy. Okay. Appendix position is can vary. It could be something called retrocecal or pelvic site. There is also multiple other sites. It could be number one, pre-ileal and post-ileal, and pelvic and subcecal and retrocecal. What is the commonest site of the appendix? Is retrocecal around 75%. What is the second commonest site? This one is around 10%, and then pre-ileal, post-ileal, and subcecal is not very common. Okay, what is a blood supply of the appendix? So basically, as we mentioned earlier, if this is your aorta, so you have at the upper border of L1, you have the celiac trunk, and then at the lower border of L1, you have the superior mesenteric artery, which supply the midgut. So the superior mesenteric artery, it gives many branches. To this side, it will give multiple branches, which is called the right colic branch. Right colic will start supplying ascending branch, and descending branch that gives appendicular branch. So it is the appendicular artery, which is coming from something called the iliocolic artery that is coming the superior mesenteric artery, okay? And the appendicular vein is the venous drainage that goes to the superior mesenteric vein. Remember, where does the superior mesenteric vein go? Can anyone tell me the superior mesenteric vein, what does it join at the end? Can anyone remind me?
The midgut?
Yeah, I know, but I mean, the superior mesenteric vein joins another vein to form another vein. What is it? So if you just go to this diagram, I just mentioned it here. So this is superior mesenteric vein. It joins the splenic vein and forms the portal. Yeah. So focus. All right. So we have here appendicitis pain is referred to the umbilicus because the pain usually starts peri-umbilical region, and they do have, and then the visceral pain is just like transferred to the right iliac fossa because both of them have the dermatome of the T10 level, I mean, embryologically they have the same origin just around the umbilicus, but the appendix sort of migrated to the right iliac fossa. So that's why the pain started as peri-umbilical first, and then it started to migrate to the right iliac fossa. Well, okay, here we're going to talk about two fossae. Number one is the cubital fossa, which is just right there in your cubitus, which is where you find the big veins to either cannulate or collect blood. So number one, if you look here, this is your biceps, and this is the bicipital aponeurosis just down there. So the biceps muscle, and down here you have a muscle called pronator teres. Comes from the common flexor origin, and then the other side you have a muscle called brachioradialis, which is lateral. So obviously we're talking here, this is lateral and this is medial, right? So again, you have number one, this is a muscle called the biceps and ends with bicipital aponeurosis, all right? And here you have pronator teres muscle, comes from the common flexor origin, just right there in your medial side of the elbow. You have more than like 5 muscles originating from here called the common flexor origin. It starts with the pronator teres, and then multiple other muscles like flexor corpularis, flexor corpularis, longus, and so on. And on the other side, you have the brachioradialis muscle. So if you look at that, there is a small triangle in here. So we're just going to take about the boundaries of this. So number one, what is the lateral boundary? As we mentioned here, this is its lateral boundary. So it's the medial border of the brachioradialis muscle. What is its medial border? So it's basically the lateral border of the pronator teres muscle. What are the superior border? It's a hypothetical line, just an imaginary line that passes between the 2 epicondyle. This is the medial epicondyle, and this is the lateral epicondyle. So it's just an imaginary line passing between them. What are the contents? Basically, you're looking for the brachial artery. The brachial artery is very deep in the content, and the bicipital aponeurosis, and the bicipital tendon, and the median nerve. Bicipital aponeurosis, bicipital tendon, and the median nerve. And also in its floor, you have the median vein, all right, which connects between cephalic and basilic vein, okay? And this is the vein that you usually cannulate or puncture for blood. Okay, so this is the cubital fossa, and we know its importance now. It has the brachial artery, the median nerve, and also the bicipital aponeurosis, and it has in the roof, it does have the median cubital vein, all right? Popliteal fossa, it is the equivalent that is present in the lower limb. So it's basically behind your mid joint, which is the knee, like your mid joint here, which is the elbow. But so from the back, we have a muscle called biceps femoris. Biceps femoris, it's just right there. So this is a muscle called biceps femoris. And on the other side, you have something called semitendinosus and semimembranosus, semitendinosus muscle and semimembranosus muscle. Okay, so obviously, again, this is the lateral side, and this is medial, and this is medial. So on the medial side, you have semitendinosus and semimembranosus. Okay, and on the lateral side, you have your biceps femoris in the lower limb, and just below here, you have a muscle called gastrocnemius muscle, which is the biggest muscle in the leg. So it's called biceps femoris, a gastrocnemius muscle. So what are the boundaries? What are the boundaries of the popliteal fossa? And what are the contents of the popliteal fossa? So if you look at the boundaries, again, so the upper medial and upper lateral, and then lower medial and lower lateral, or because it's a diamond shape, like, I mean, it's diagonal shape like that, okay? So upper medial, we're right there. So it will be semitendinosus and semimembranosus muscle. Upper lateral will be the biceps, and then, okay, so upper medial and upper lateral, we know that, and then lower medial is the gastrocnemius muscle, lower lateral is the gastrocnemius muscle. What are the contents? You have number one, the common peroneal nerve, we mentioned that early, and the tibial nerve. So basically, at the upper end of this fossa, the sural nerve is started to divide into tibial nerve and common peroneal nerve, which is lateral and which is medial. So the most lateral structure is the common peroneal nerve, because you know it is going to the lateral end of the fibula, right? And then the tibial nerve. So you have two nerves, common peroneal nerve and tibial nerve, and you have the popliteal vein, you have the popliteal artery, and some lymph nodes present in this area. Popliteal artery is, you know, guys, the same concept that I mentioned earlier for the aorta. If you remember, where is the aorta in here? Is it T10, 12, or 8? So you remember, we need to protect the artery. So it will be the deepest structure. So it will be T12, okay? Again here, where is the popliteal artery? It's an artery, you need to protect it. It is the deepest structure. It will be just in the bone, okay? However, that puts this artery at high risk of injury if you injure your knee, okay? So it will be the very first structure that is injured. What is the most superficial structure in the popliteal fossa? The most superficial structure is the common peroneal nerve. This is why it is at higher risk of injury during surgery. Okay, so all think about that. You have the common peroneal nerve, the most superficial, the popliteal artery, the deepest structure, and it puts both of them at risk of injury. One is during surgery, the other is during injury. Well, brachial plexus, we need to know what are the roots of the brachial plexus, the trunks, the divisions, the cords, and the terminal branches. Okay, so let's talk about the roots. You have C5, 6, 7, 8, and T1. C5, 6, 7, 8, and T1. Okay, so these are called the roots of the brachial plexus. So that's a root, and then that's a root, and then that's a root as well, and that's a root. Okay, so the upper two roots, 5 and 6, unite together to form the superior trunk. The lower two roots, 6 and 7, unite together to form the inferior trunk. And the middle trunk is a continuation of C7, basically. It does not unite with anyone. And then each trunk will divide into two divisions. So each trunk will divide into two divisions. So superior trunk will give you posterior and anterior division. Middle trunk will give you anterior and posterior division. Inferior trunk will give you anterior and posterior division. Then what happens to division? All the posterior division will unite together to form a posterior cord. The anterior division of the superior and the middle trunk will give you the lateral cord. And the anterior division of the inferior trunk will just continue on its own to form the medial cord. And then the cords is the site when you get loads of branches in the cord. Okay, so basically all the branches come from the cord, and we're going to mention this. So what are the branches of the brachial plexus? So think about it. We have roots. The roots give some branches. The most important one is the long thoracic nerve. The long thoracic nerve, which is C5, 6, and 7, give you the long thoracic nerve. Okay, so long thoracic nerve is C5, 6, and 7. Well, you have from the superior division, the superior trunk, you have suprascapular nerve and nerve to subclavius. These are the only branches. Divisions gives no branches. There is no branches from divisions. The cords give them many branches. So the lateral cord will give you the lateral pectoral nerve, the musculocutaneous nerve, and part of the medial nerve. The medial cord will give you many branches, okay? And these branches are ulnar. So number one, ulnar. The L will be, we'll give it number one, the ulnar, and it will participate in the median as well. And it will give the medial cutaneous nerve of forearm, medial cutaneous nerve of arm, and medial pectoral nerve, okay? What is the posterior cord branches? This is the posterior cord. Will give number one, axillary, number two, radial nerve as well, which is solely from the posterior cord, and it will give subscapular, thoracodorsal, and inferior subscapular nerve. So these are basically the branches from the cord. Do you need to memorize all the branches? I would say no, to be honest. I would say the long thoracic nerve is something important. Know its roots. I would say know where is the musculocutaneous nerve, the median nerve, radial nerve, and the ulnar nerve are coming from. These are the main branches, okay? And then you divide it. You have here the lateral cord, it gives the lateral pectoral. The medial cord, it gives the medial pectoral. And then some cutaneous branches. One give here the medial cutaneous nerve of arm and forearm, and the other here will give the lateral cutaneous nerve of the arm and forearm will be coming from the musculocutaneous nerve, okay? So these are the main things that you need to know. So we basically mentioned all of this. Then again, the origin of the ulnar nerve, where is it coming from? It's coming from the medial cord. You know that, remember that? So this is the medial cord, gives ulnar nerve. Okay, it gives 5 branches basically. What is the origin of it? So if you track it back, so this is the medial cord. Where is it coming from? Medial cord is coming from C7, 10, and 8. C7, 7, 8, and T1. 7, 8, and T1. What is the radial nerve coming from? It's coming from the posterior cord. Remember that? Posterior cord. And the posterior cord is basically taken, if you track it back, so it's taken from the superior division, middle division, and the inferior division. I would assume it's all the things. So it's C5, 6, 7, 8, and 1, because it is the radial nerve taken from all the posterior divisions, if you remember that. The posterior divisions all unite together from the posterior cord, once you get the radial nerve. So it basically takes from all the roots, right? The median nerve, where is it coming from? It's not from just one cord. So it's basically taken from the lateral cord and the medial cord. So again, it will take from all the roots, 5, 6, and 7, 8, and 1. All right. Well, now let's talk about the nerve injury. So radial nerve is taken from the posterior cord. What does it supply? So basically, the radial nerve supplies all the posterior compartment muscles. So it will basically supplies all the extensors of your wrist. What if your radial nerve is injured? So you will lose all the extensor muscles. So your wrist will drop, because basically what's keeping your hand like that is the balance between the extensors on this side and the flexors on this side. So if you lose the power of the extensors, your wrist will drop like that. So this is wrist drop. What does the radial nerve supply sensation? The anatomical snuff box area. So you will lose the sensation in this part. There are two common sources of injury in this for radial nerve. That's called the crutch palsy. You know that all the crutches that people used to have that puts a lot of pressure on their armpit that might injure the radial nerve, and also Saturday night syndrome. When people sleep like that after drinking so much, they will enter the radial nerve and will have Saturday night palsy. All right. So these are the injury of the radial nerve. Always remember rest drop and loss of sensation, Saturday night, and the clutch palsy. What happens to the ulnar nerve? What does the ulnar nerve supply? So the ulnar nerve supplies basically all the flexors in this part, all the flexors of your forearm, and also supplies the medial 1.5 finger sensation in this part, okay? But it also supplies medial two lumbricals, the medial two lumbricals in this area. So always focus with that. So what keeps your finger like this? It's very straight or in a neutral position at the balance between the flexors on this side and the extensors on this side, okay? So the lumbricals are one of the extensors of your fingers. The lumbricals is able to extend your fingers. Lumbricals are supplied by your ulnar nerve. And lumbricals are extensors with the radial nerve muscle on the back. So what happens if the radial nerve is injured at your wrist? Okay, so it will affect the muscles on this part, which is the medial two lumbricals. But there is a big muscle in here. It's called the flexor carpialis, which is also participating in the flexion. So this muscle will not be affected if you injure the ulnar nerve at the wrist. So this muscle will be working, and you've lost one of your extensors, which is the two lumbricals. So the extensor force is slightly weaker than the flexor force. So now your fingers will be like that. And we call this claw hand, okay? Claw hand. And obviously loss of sensation of your little finger and the medial part of your ring finger, right? So this is basically your claw hand. Okay, what happens when you injure your ulnar nerve at the elbow? So basically now you lost the flexor carpialis on the medial side, which is the main flexor of this area. And you've lost the extensor power as well, which is the lumbricals. But now the extensor power on this side, the radial nerve, is working. And the ulnar nerve is completely not working. So what will happen is you will have less clawing. It will be just like that, because the extensor power is now higher than the flexor power, because you've lost here flexors and extensors with the injury at the elbow joint. So this is called ulnar paradox. The higher the lesion, the lesser the clawing. Okay, so this is how to explain it. It's basically the balance between the power of the flexors and the extensors. Okay, what happens if you injure the median nerve? So median nerve basically supplies some of the flexors on the lateral side of the forearm and also the hypo or the thenar eminence, sorry, and also supply the thenar eminence. So what will happen? You will have a very flat hand in this part, and you'll have parathesia in this area, and your thumb will be just like paralyzed because you've lost your thenar eminence, and they will call that an ape hand. Your thumb will be basically like that. Okay, we'll call that an ape hand. Well, there is two more injuries, something called Erb's palsy and something called Klump's paralysis. Both of them happen in pediatric patients during delivery. So in Erb's palsy, it's called a policeman tip paralysis, and there is an upper trunk injury. Do you remember what is the upper trunk? So this is your upper trunk or the superior trunk. So basically your musculocutaneous nerve and part of your median nerve will be affected. So you will basically have sort of hand drop, rest drop, your hand will be just rotated like that in this image. And so basically it is abducted and internally rotated by the dominating power of the lower and median trunk. So the arm is medially rotated, the elbow is extended, and the forearm is pronated, and the rest is flexed. So it's basically a rest drop. So this is called Erb's paralysis. What is Klump's paralysis? So imagine that if you are falling from the third floor and then suddenly you hold a tree while you're falling down, so it will pull all the arm up, so it will injure the lower trunk. This is the story usually. So it's a lower trunk injury. So you have complete glue hand will look exactly like this. Okay. So basically you injured your ulnar nerve, basically, or the lower trunk. So your ulnar nerve has been injured and part of the radial nerve as well. So long thoracic nerve, this is a very common injury which happens. Does anybody know the story? When did the long thoracic nerve injury happen? There's a very common story in medicine that how does the long thoracic nerve injury happen? Does anybody know?
Basketball players, but I can't remember why. No?
No. Long thoracic nerve. It happens after surgery. So it happens after mastectomy, all right? So long thoracic nerve supplies basically the serratus anterior paralysis. So it's very common after the mastectomy in breast cancer patients. So when this happens, when you ask them to try to push forward, you will find that the scapula is very winged because of the serratus anterior muscle paralysis. So this is long thoracic nerve. Hypoglossal nerve. So basically, if this is your tongue, so the muscles will make an X shape. So let's say the muscles on the right-hand side will be able to bring the tongue to the other side. So I mean, because it's like an X-shaped muscles. So this bring it to the other side and this bring it to the side. So deviation of the tongue toward the paralyzed side happens if you the hypoglossal nerve is injured. Let's say the hypoglossal nerve is injured in the right side, so the muscle, the tongue will still be brought to the right side because the muscles, if you know what I mean, the muscles are supplied in an X-shaped. Glossopharyngeal nerve, it's the 9th cranial nerve, and it will lead to, so what is the nerve supply, the sensation of the tongue? So if this is your tongue, the anterior 2/3 of the tongue supplied by the general taste will be supplied by facial nerve and lingual nerve. And so the taste is the facial nerve and the general sensation is the lingual nerve. And the posterior third, taste and general, will be supplied by the glossopharyngeal nerve. So glossopharyngeal nerve injury will lead to loss of sensations, taste and general sensation, the posterior third of your tongue. Facial nerve, I think we explained it last time pretty well. The vagus nerve paralysis, it's responsible for your cough reflex and your phonation. So you will have very weak cough and dysphonia as well, or vocal cord paralysis. And also it supplies your gut and the diaphragm as well, part of the diaphragm. Your trigeminal nerve, you remember the trigeminal nerve, which is your fifth nerve. There is a ganglion in this area that gives 3 branches. It's basically the ophthalmic division, and then the mandibular division, and then the maxillary division. So it will lead to loss of all these muscles. Following that, we have the oculomotor nerve. I think we explained again last time. So the oculomotor nerve. So if this is your pupil, it has a muscle around it. It's called the circular muscle. And this is supplied by the oculomotor nerve. And this circular muscle, when it contracts, it causes pupillary constriction. So, and also it supplied the another muscle called the levator palpebrae superioris, which is responsible for elevation of your upper eyelid, and it supplies some of the extraocular muscles. We explained that last time. So all the extraocular muscles supplied by the oculomotor nerve, apart from SO4, superior oblique, supplied by 4, and LR6, lateral rectus, supplied by the sixth cranial nerve. So what happens if you have oculomotor nerve paralysis? So the circular muscle will be paralyzed. You will have mydriasis, and there is loss of function of levator palpebrae superioris. You will have drooping of the upper eyelid. You can't open your upper eyelid again. And the last one, loss of function of all extraocular muscles, apart from SO4, the LR6. So have a gaze down and out due to the effect of the superior oblique muscle. What happens if SA4, so superior oblique, is paralyzed? So basically the superior oblique is coming, so as I mentioned last time, it's coming all the way here, and then it hooks around the supratracheal notch and then goes backward. If this is your eyeball, it will supply it like that. So when this contracts, basically it will be shortened like that. So it will, and this will be going forward like this. So it will push the eyeball down and out, which is the case here, right? So what if this did not is not working anymore? Superior oblique is paralyzed, so all the other muscles will be dominating. Double vision on climbing, looking up and down. Superior oblique is the muscle when used in reading. So basically, when I'm looking down like that, this is the superior oblique muscle. Abducens nerve, or the sixth nerve, which is the longest nerve in one of the longest central nerves, and it's at high risks of injury. So it's basically supplied the lateral rectus. So let's say if the right abducens nerve is paralyzed, so this is my right eye, this is paralyzed. When I'm trying to look towards my right side, so this eye will be moving like that, and this eye will be fixed. So I will have double vision. But when I look to the healthy side, which is the left, it will be absolutely working. So basically, you have double vision while looking to the side, the affected side, okay? So right, looking at the right, so it's right nerve. Looking at the left, it's left nerve, all right? Axillary nerve, numbness is the superior aspect of the arm, just below the shoulder joint. So fracture of the humeral neck leads to axillary nerve injury. Musculocutaneous nerve, we mentioned loss of consistency. It supplies the lateral, it gives the lateral cutaneous nerve of the forearm, lateral cutaneous nerve of the forearm. So this will be lost, and the flexion of the elbow because it supplies the elbow flexors, which is the biceps muscle and coracobrachialis. Shoe roll is lateral of the foot, so loss of sensation in this part. Saphenous nerve is on the medial side of the foot, and you have here the spinal accessory nerve. It's responsible for shrugging your shoulder basically because it supplies the trapezius muscle. So will be unable to move this part. The tibial nerve, so you have something called tib and ped. So differentiation between your tibial and peroneal nerve. So the tibial nerve is responsible for inversion and the plantar flexion, inversion and the plantar flexion of your foot, and the ped, which is the peroneal nerve, responsible for eversion, going out, and dorsiflexion. We explained again the superficial peroneal nerve. Superficial peroneal nerve supply the sensation on the dorsum of the foot apart from the first web space, right? Deep peroneal nerve, so it supplies basically the first web space. Sorry, guys. Okay, so this is the deep peroneal nerve. You have here as well the sciatic nerve. Sciatic nerve is on the back, which is part of two nerves, the tibial and common peroneal nerve. It supplies all the muscles on the back of your thigh. So it's basically all the hamstrings muscle. And again, all the muscles below the knee as well. So it's responsible for the foot drop and loss of sensation below the knee, because basically all the sensation on the back is from the sciatic nerve, which is the common peroneal nerve, or is the sciatic nerve as well. So basically, the common peroneal nerve continues on the lateral surface of the leg, and it supplies all the muscles in the posterior compartment of the leg, superficial and deep, and also it gives sensation to all the dorsum of the foot, including the first web space by the deep peroneal nerve. So again, I mentioned that early femur neck fracture, acetabular fracture, or the lateral end of the fibula will lead to this issue that we mentioned. Yeah, so the femoral nerve is basically supply the anterior groove of the thigh. So it's responsible for basically the quads, your quads, quadriceps, the vastus medialis and vastus lateralis and vastus intermedius, and the quadriceps femoris, which are the four parts of the quad muscle. It also leads to paresthesia in the front of the thigh. We mentioned this early. So obturator nerve, if you remember, responsible for the medial sensation and also responsible for the medial muscles, which is hip adduction, hip adduction. So again, recurrent laryngeal nerve is a branch from the 10th, so branch from the vagus muscle, vagus nerve. And if there is unilateral, so it's basically supplied the muscles of the vocal cord, right? So if there is unilateral paralysis, it will lead to hoarseness of voice. If it's bilateral, you will have aphonia, or you cannot like produce any kind of voice. But if it's unilateral, it will lead to hoarseness of voice. Okay, the external laryngeal nerve. So again, this is the branch from the 10th, and it causes dysphonia. And the external laryngeal nerve supply the cricopharyngeus muscle. So all the muscles of the larynx are supplied by recurrent laryngeal nerve, except cricopharyngeus muscle, which is supplied by external laryngeal nerve. Inferior alveolar nerve is a branch from, is basically supplied, so it's branch from the mandibular nerve, and it supplies the chin and the lower mucosa and the lower lip as well. This is your inferior alveolar nerve, and this is the nerve which you get anesthetized during your dental extraction or something like that. Okay. So the lymphatic drainage is also something that usually comes, specifically these areas. So the skin of the scrotum, vulva and perineum goes to superficial lymph nodes. Your gonads and lateral foot goes to superficial inguinal lymph nodes as well. Your gonads, testes, and ovaries also goes to the para-aortic lymph nodes. So this is important for cancer testis or cancer ovary. It usually goes to the para-aortic lymph nodes. Lateral foot, it goes to the popliteal lymph nodes. Deep lymphatics of the lower leg, glands, and clitoris, it goes to the external iliac lymph nodes. And tip of the tongue goes to submental lymph nodes. And anterior to third of the tongue goes submandibular lymph nodes. And posterior third of the tongue goes to the deep cervical lymph nodes. So all of this is honestly very important. So again, your tongue divided into the tip and the sides and the posterior part. The tip goes to the submental lymph nodes. Here, submandibular lymph nodes. Here, deep cervical lymph nodes. Okay, and then go to your gonads. Testis and ovary go to the para-aortic lymph nodes, and the sensations from the skin, scrotum, vulva, and perineum goes superficial inguinal lymph nodes. And also the lateral foot, popliteal lymph nodes, and deep lymphatics of the leg goes to the external iliac lymph nodes. All right. Okay. So guys, we have loads of things to explain in orthopedics as well. So I will leave the notes for today. You can read the notes, and if you have any question, you can always ask me later, because I probably can't finish everything in just one session. So I will leave the notes to you, and you read the notes, and if you have any question, ask in the group, and I'm happy to make you some videos that you can watch. All right. Does anyone have any questions so far?
No.
Any questions? Okay, so we'll move on to our orthopedic topic today. So the first thing we're going to talk about is something congenital. Before I carry on and speak about orthopedics, I just want to show you very quickly what is your main assessment, the orthopedic assessment. What do you usually do to get like a full orthopedic assessment for your patients? All right. Just one sec. Okay. So basically, when you're examining any orthopedic patient, you need to, number one, look, number two, feel, number three, move, number four, do your neurovascular assessment. Okay. All right. What are you looking for? I'm looking for any swelling. I'm looking for bruises. I'm looking for any deformity. I'm looking for any wound. Right? So this is basically your secondary survey. So you only have a patient was presented to you with trauma, and you need to find out what has happened to this patient and examine them and find if there was any kind of fracture or potential imaging that you need to do. So you need to look, feel, move, and do neurovascular bundle. So number one, when you're looking, I'm looking for if this bone or this tissue swollen, is there any bruise or abrasions, is there any deformity between the other side compared to the other side? Can I see any wound that is completely open and this is potentially an open fracture? This is basically what you're looking for. You're also looking for the color, if there is any like erythema or any hotness in this area or things like that. Number two, you're feeling. So you're feeling to assess for tenderness. So you're basically assessing the pain. And number three, you're assessing for the hotness as well. Is it hot or not? All right. And you're also assessing if there is a swelling or a mass. For example, you will assess the mass as its side and its size and its shape and its surface and its skin involvement. So it's the 5S, the 5 magical S. After that, you will do the movement, and the movement is either an active movement. When you ask your patient, can you move this leg for me? Can you move this hand? Can you move this joint? And number two, passive movement, when you go and do it yourself. And basically, when you're examining any joint, you're doing the movements in all the cardinal directions, in all the directions that it can move. So basically, my wrist, for example, it can do flexion, it can do extension, it can do adduction, it can do abduction, and it can do circumduction as well, just like that, right? And it can do pronation, and it can do supination. So you need to examine the rest in all the directions. So what I've just done is active movement, but what you can do later on, if I can't move it, you will take it to me and ask me, is this painful to you? Is this painful to you? Is this painful? You do it again in all the direction that it can move. Again, your shoulder can do abduction, adduction, flexion, extension, and then circumduction, right? So you do for each joint assessment, you basically do active and passive movement and all the movement that it can gain. And then you do your neurovascular assessment. So basically, you're examining the dermatomes and myotomes that we just mentioned. You're trying to find out if there's any abnormality with the sensation in this area, and also the myotomes, which is the muscular nerve supply. And finally, your assessment, you pulse. You're trying to see if there is any arterial injury or something that, like we mentioned earlier, if you have a femur fracture, distal femur fracture, it will affect your popliteal fossa, and the artery that is at risk of injury is the popliteal artery, which is the deepest structure of the popliteal fossa, if you remember that. So this is basically it for the assessment of orthopedic patient. The first one, we're talking about something called developmental dysplasia of the hip, DDH, so formerly referred as congenital hip dislocation or congenital dislocation of the hip. So it's basically a child, which is most of the time a female, as a child and presented with breech, right? Usually she is a little bit obese as well, okay? And presented to you after vaginal delivery with some hip problem. And usually the mother will mention to you, so doctor, when I'm changing to her, I feel like there is a click coming out of the right hip and it's very deformed. When you examine the patient, what you will do, you will look, feel and move and do a neurovascular, which is a little bit difficult in examining a child for neurovascular examination, but you can always do the look, feel and move. And in the movements here, we have two special tests, something called Barlow test and something called Ortolani test. So the Barlow, so you will attempt to dislocate the hip. It's a very bad test that we don't do, and we do not recommend that you do it. Ortolani test, we are basically assessing if the hip is you're basically doing relocation of the hip into the right direction, okay? So there is a link in here. You can watch the videos for Barlow and Ortolani test. So ultrasound is the confirmatory. So this is the best investigation to do. So why are we doing ultrasound and not an X-ray? Because that's a child, and it's not recommended to do an X-ray for a child below 6 months. So, and most of the presentation is below 6 months. Most of the presentation is at birth. So hanus is a very good tool in investigation. So what's your management? There is something called Pavlik hanus, which is some kind of a cost that takes all the hip down to the leg and keeps the joint in the right place for a longer time, maybe 4 to 6 months or maybe up to a year. And it will keep it aligned until the child grows and things will be better. Sometimes there is surgical intervention as well that is being done, but it's not very common because Pavlik hanus cost is very successful. So again, you have a child, usually a female, presented at birth with some hip problem and presented usually fatty and presented vaginal delivery and the breech as well. You do your examination, look, feel and move. There's two special tests, Barlow and the Ortolani test. Ultrasound is confirmatory and your management is Pavlik hanus or surgery. There is something called SOFI. What is SOFI? Okay. Slept upper femoral epiphysis, something called the slept upper femoral epiphysis. So basically, if you look here, this is the femoral head, and this is the diaphysis of your femur. So this is the end of your femur. So the presentation is usually a 13-year-old, not necessarily 13, but older than 12. Somebody who's older than 12 and usually obese, presented to you by limping and knee pain. You do your X-ray in the hip, you will find that this is the growth plate or the epiphysis. Growth plate is a very old name. We call it epiphysis. You will find that the head of femur is slightly slept downward. So this is something called a slept upper femoral epiphysis. Okay. What is the issue with that? The growing. So because the epiphysis is your growth plate, so you're not going to grow from this area and you will have limping for the rest of your life. You will have a shorter limb than the other one. So basically it's very important to get it done in the right place. Okay, so again, what is your examination and your assessment? You will look, you will find some deformity. We said earlier that we're looking for deformity. What kind of deformity here is asymmetrical limbs? Is basically shortness on one limb than the other. Okay, so
Got a
number
little
one, sorry.
about what I just ring on my head. What you said about the epiphysis as growth plate, I knew it was metaphysis.
Sorry?
That the growth plate is contained within the metaphysis rather than the epiphysis.
Well, sorry about that. There is something called the physis. Okay, physis is your growth plate. I'm sorry, I said it's epiphysis. It's not epiphysis. Something called the physis. This is your growth plate. All right. The area above it, which is basically here, the head, is called the epiphysis, and the below it is called the diaphysis, basically. All right. If you want to call something metaphysis, this is the metaphysis. It's basically the physis and the diaphysis. Does that make sense?
The epiphysis, I know it's metaphysis and diaphysis.
Sorry, what?
It's not physis, it's metaphysis because it's right in the middle and it contains the growing plate.
Well, that's kind of old. It's a.
Oh, so that's what you were saying, that it's old.
Yeah, this is kind of old. There is they don't call anything like the growth plate is a very old name that they don't use it. Number one, the metaphysis is something also that is old that they don't use it. I was quite surprised when this happened because I worked in orthopedic for a year last year at King's College, and that was explained to me this way from the consultants. So basically, there is nothing called the growth plate at the moment. This is very old, and there is nothing called metaphysis or things like that. I mean, it's still in our books that we study, but basically the growth plate is, they call it physis and epiphysis and diaphysis, basically. So this is the differentiation now. So your physis is the growth plate. The area above it is your epiphysis, and diaphysis is below it. I hope this is clear. Hello. Shall we carry on? All right, I'll wait for your question if you still have questions. So again, there's something called the physis, which is your growth plate, and above it is the epiphysis, and below it is the diaphysis. So the problem with the sulci, or the slipped upper femoral epiphysis, is your epiphysis, this part, is slightly slipped from your physis. So you will be presented with pain and limping, and there will be shortness of this side, and you're unable to abduct your limb, and the hip will be slightly flexed and external rotated. It's exactly like neck-femur fracture, and external rotation of the hip is very painful as well. Okay, so this is basically slipped upper femoral epiphysis. How do we treat that? So it's basically surgical intervention for most of the patient. However, this is a very rare presentation. There's also something called birth disease. So we basically talked about DDH, which is from 0 to 3 years. We talked about SOFI, which is basically after 12 years or from 9 to 15 years. And birth disease is from 3 to 9 years. So basically you have a 3 to 9 year old presented to you with very bad pain in their hip that has been there for years, maybe 1 or 2 years. And birth disease is due to inflammatory process that happen in the your hip joint. So there will be some stiffness and the reduced range of motion, and the x-ray, when it's done, there will be widening of the joint space and increased density of the femoral head epiphysis, and the flattening of the femoral head with the decussance of the epiphysis. So basically these are the differentiation. So you differentiate between them by the age is the most important factor. And the DDH is usually painless. It's either dislocatable or relocatable. And the SOFI is very painful in a child who is obese and more than 12 years old. And risk factors for DDH is a female, first child, slightly obese, and delivery was breech, and you have unequal skin fold on both sides, and the one leg is slightly shorter than the other. Again, on the SOFI, you'll have one leg is slightly shorter than the other as well due to problem in the growth. All right. So this is, again, a birth disease. We explained that. So it's basically avascular necrosis of the head and some kind of inflammatory process as well that follows the avascular necrosis of the head. The patient will be presented by pain that has been there for a very long time. Any questions so far? All right. So osteoarthritis is basically some inflammatory change that happen in any joint. It could be something called monoarthritis. Monoarthritis means it's a single joint problem, all right? The commonest joint that are affected is your hip and your knee, commonly affected. The wrist and the hand can be affected as well. The joint pain is exacerbated by exercise and relieved by rest. So basically, the patient, the typical story, when the patient wakes up, all right, they are absolutely fine, and during the day, the pain starts to increase, and by the end of the day, it's very bad. There is something called Bouchard nodes and Herpin's nodes. These are due to accumulation of inflammatory cells in the joint. So Bouchard is basically happen in the proximal, and Herpin's basically happen in the distal interphalangeal joint, because the B comes before the H. So the B comes before the H, all right? So Bouchard nodes here and the Herpin's nodes is in the distal interphalangeal joint. So when you do an X-ray, so basically, again, your assessment here, you will look, you will find some obvious deformity. You might find some swelling. You might find some nodes that is called Herpin's and Bouchard nodes, and you might find asymmetry between joints on both sides. When you try to feel, it will be swelling. So you will assess for the swelling, slightly tender in examination. When you try to move, there will be limited range of motion, and doing neurovascular bundle will probably be intact. And here, when you do an X-ray, there will be loss of joint space. Osteophytes are present. What are osteophytes? So basically, if this is your knee joint, there'll be some bony protuberance coming from the bone. These are called osteophytes. And subchondral cyst or subchondral sclerosis. So again, if this is a bone, there is something called it's a chondral space here that makes the joint very, very soft. So just below this cartilage, so there is cartilage in here. So below this cartilage, there will be a cyst, or it will be very sclerotic due to calcium deposition. When we do a T-score, it will be minus 2.5, and you will see that in a bit. So the management is basically physiotherapy and decrease in body weight, do some painkillers for them, like paracetamol, or topical NSAIDs as well can do that. Or basically you're supporting the patient with some kind of pain management, all right? The last resort here is you might do joint replacement, basically like hip replacement or knee replacement, since they are the commonest sites. And this procedure or operation is done on elective basis. It's not urgent procedure, okay? So for all your patients who are presented with osteoarthritis, give them paracetamol. They're not taking it. If they are at risk of gastric ulcers, do not give NSAIDs, but you can give the COX-2 inhibitors that decrease the risk of gastric upset. Although X-ray would be helpful, a routine X-ray is not needed to confirm your diagnosis. Well, most GB were to treat the osteoarthritis with just painkillers and get them reviewed by a consultant orthopedic if they need some replacement. So again, if you remember that, this is something called the osteoarthritis. And if you look here, there is loss of the joint space and there's no osteofiber, let's assume, and also there is subcondylar sclerosis and subcondylar cyst that might be present in your X-ray assessment. We have something osteoporosis. The P is a problem with the protein, okay, deposition. So basically, with age, you will have some kind of decreased bone quality. So your bone quality will be affected with age due to decrease of deposition of protein in your bone. So it's usually, I'm not sure what's happening with my, can you guys still hear me well?
Yes, we can hear you.
Yeah, excellent. So osteoporosis is a problem with your protein deposition in the bone, and your bone will be more liable to fracture. There is multiple risk factors for osteoporosis. The age is the most important, and some drugs, the two things that I remember very well is levetiracetam, the anti-epileptic medication, and omeprazole. Okay, these are the two very important medication, and obviously the cortisone as well does increase the risk of having osteoporosis as well. Okay, the treatment for that is to give them something that helps deposition of calcium in the bone, and this is bisphosphonate or alendronic acid. This medication, just to know a few things about it, it's given weekly, on a weekly basis, in a single day, and it does increase the risk of gastric upset. So the patient will need to take it while they are standing with a 2 glass of water, and just to make sure that they're not hurting their stomach, all right? You can give to the females tamoxifen or a selective estrogen receptor modulator and some calcium supplement like the calcium supplement or vitamin D as well can be given. Okay, so the dose is 70 milligram. It's given once weekly or 10 milligram once daily, but the weekly one is better because the patient will be more compliant and less likely to forget, because they're going to be taking it 4 times a month, not 30 times a month, right? The side effect is dyspepsia and gastric reflux, and we mentioned that the patient will need to be taken it standing with 2 glasses of water and remain standing for like 30 minutes. Osteoporosis is painless. Osteomalacia is painful. So again, if you remember, I said porosis is a problem with your protein. Malacia is a problem with your mineralization, right? Mineralization. So it's basically a problem with your calcium. Long-term steroid use leads to osteoporosis. We mentioned as well the levetiracetam and the omeprazole, right? Levetiracetam and the omeprazole. So monoarthritis, we mentioned it, it's pain least in the morning and the increase in the day lead to osteoarthritis. We mentioned, so again, if the pain is not there in the morning and increase with exercise or increase during the course of the day, it's called osteoarthritis, all right? More than one joint is affected, so it's multiple joints, and pain is worse in walking and improved during the day, and waking up. So the pain is very bad in the morning, and during the day, it will improve. This is called rheumatoid arthritis, okay? The T-score is something that we can do by a scan called DEXA, or to measure the bone mineral density. So it's like a standard deviation. So -1 or high, or it's not minus, it's like deviation by 1 from the 0 point is normal, At between -1 to -2.5, it's called osteopenia. You need some lifestyle modification. And if it's less than 2.5, like 2.7 or something, that means you are osteoporotic and you need treatment for that. So according to NICE guidelines, bisphosphonate should be offered based on something called the FRAX or the Q fracture. And it's something, I mean, the FRAX or the Q fracture is something that we usually make it online. So you just open the website and just start writing the patient age, the patient diseases like diabetic or hypertensive or all the risk, and it will be calculated and it will tell you the risk of the patient of having fractures for the next 10 years. And then you will be able to start treatment based on this guidance. So you can always just write Q fracture or FRAX on the internet and you will get the scoring system. Well, osteoporosis risk assessment, elderly patient, especially women who are menopausal as well, are more likely to sustain fracture, specifically neck or femur fracture. Therefore, patient at risk of osteoporosis should be investigated and treated by having, number one, DEXA scan and doing a fragility score for them, all right? So we need to do all the assessment for any patient or any female patient who are above than 50. Okay, so we're gonna talk a few about some kind of common injuries that happen in the hand. So we have something called mallet finger or mallet finger. You can just pronounce it the way you would like. So it's basically injury to the extensor digitorum profundus. So on the back of your hand, you have a muscle called extensor digitorum. It has like 4 digits attached to each finger. So if this muscle is injured or this muscle tendon is injured, it's usually attached to the distal and the distal phalanx. So if this muscle is injured, so again, you will lose the balance. So the balance here should be equal to here. So if we have like 2 here, so it should be equal to have your hand in neutral position. What happens if this balance is affected? So it will be just 1. So your distal phalanx will be flexed, okay? So it's basically hyperflexion of an outstretched finger causing it to bend, and this is called mallet finger, okay? Mallet finger. What you need to do is get this back in position in a splint, all right? And keep it there for probably 6 weeks to 8 weeks, and it will heal by its own. There is something called trigger finger or something called this tenosynovitis. So what happens here, so it's most of the times it does affect your thumb or ring finger or little finger. Is basically flexion is normal, but beyond, it's normal flexion, but beyond a certain range of motion. The patient will have difficulty extending their flexed finger. So basically, if you look here, the finger is flexed. When you try to extend it, the patient try to extend it, they will hear a click. And this is basically due to presence a nodule in the flexor digitorum of that finger. That happens usually with people who do a lot of shooting by using their fingers. So it's basically a nodule that grows in the flexor sheath that is in the hand. It's common again in the thumb, ring, and little finger. There's something called gamekeepers or skier's thumb, and the reason why they do that, the name is like this, because back in time, they were playing something called the gamekeeper. They get a chicken and try to evulse the head of the chicken by the thumb finger without using any kind of knife. So it can affect or do avulsion of a ligament in the first metacarpal joint. And this ligament is called the ulnar collateral ligament, which is present on just basically the inner side of the thumb due to the, trying to avulse the head of the chicken by this finger. So it will lead to injury of the ligament at this area. And the thumb will be very lax and hyperextended, sometimes laterally deviated, and the grip. Okay, so what you can do is give them a spica splint, and it's a splint for 604 is called the game scars. There's something called Dupuytren's contracture. It happens in 3 patients. Number 1, diabetics. Number 2, alcoholics. Number 3, cirrhotics. Okay, diabetics, alcoholics, and cirrhotics. There's thickening of the palmar fibrous fascia. It will lead to fixed flexion deformity that happens basically in the little 2 fingers. It happens in alcoholic, diabetic, cirrhotic, and thyroid disease, and also epilepsy. It could be with family history. What you can do fasciotomy for the patient, and they should be all right following this. There is something called decurvent tenosynovitis. So it's basically, if you go to your thumb, you have 2 ligaments on the lateral surface of the thumb, it usually happens with female patients who are having new kids, and you're continually holding them by their thumb. Number 1, it also happens with the students who are writing a lot. So it leads to some inflammatory changes in the tendons that goes to the thumb, at the base of the thumb. So it would be very painful at motion. So when you examine it, again, you will be trying to feel it. It will be very painful on the lateral surface of the thumb, the base of the thumb, basically. So this is called decurvent tenosynovitis. So it's pain during thumb motion due to entrapment tendinitis, due to overusing the wrist, it either with the students or the mummies, and caused by inflammation of the extensor pollicis brevis and abductor pollicis longus. Okay, so basically the muscles on the thumb is longus brevis longus. Okay, longus brevis longus. So you have here extensor pollicis brevis, and abductor pollicis longus is just right there. So due to overuse of this area, it leads to decurvent tenosynovitis. Scaphoid fracture. Scaphoid fracture. Before I explain that, this is the scaphoid bone, and you can see here there's interruption of the cortex. So that's the fracture. The blood supply of the scaphoid comes from the distal end to the proximal end. So blood supply goes just like that. So if you have a fracture in here, so this part, the blood supply will be interrupted, and the proximal part will be at risk of avascular necrosis. So keep an eye on that. So basically, fallen outstretched hand with forced dorsiflexion, you do an X-ray, you'll find it absolutely normal. But if you find any tenderness in the anatomical snuff box, and that will tell you that the patient is probably having a scaphoid fracture. So what you need to do, either do an MRI now or repeat the X-ray within 2 weeks, and it will tell you if there is anything wrong with the scaphoid. Okay, so tenderness on the anatomical snuff box, or something called compression test. So you basically put some compression from this side and from this side. If you find it very painful, so you might be thinking that it is scaphoid fracture. Initial X-rays, you can do a cast and repeat X-ray in 2 weeks. And if it is normal, you can just take out the cast. If it is abnormal, you will need to continue with the cast for 4 more weeks and monitor for avascular necrosis. Any questions so far? Questions? So remember, the mallet finger, the digitorum has been injured, extensor digitorum injured, so fixed flexion on the distal phalanx. Triggers, it happens in people who do a lot of shooting, and specifically the army people, due to formation of ganglion in this area from holding the gun, and it will lead to fixed flexion, and you will hear the snap when you're trying to do extension. Gamekeepers, due to avulsion of the medial collateral ligament of the thumb, there will be laxity or hyperextended thumb, or lateral deviated as well. Diabetic, alcoholic, thoracic, and thyroid and epilepsy at risk of Dupuytren's contracture. decurvan, overuse, mummies, student, injury to not injury, but inflammatory changes for the two muscles that we mentioned. We mentioned that here is longus, brevis, longus. So it's basically abductor pollicis longus and extensor pollicis brevis. But also happens following pregnancy as well due to deposition of inflammatory cells. All right. Again, we mentioned scaphoid fracture. We know how does the blood supply happen from distal to proximal, and it might lead to something called avascular necrosis. Forearm fracture, we have two fractures that are like brother and sister. That is called Cool's fracture and the Smith fracture. So Cool's fracture is both of them are fractured to the distal end of the radius. So basically, when you have a fall, when outstretched hand, specifically in an old osteoporotic woman, will be presented to you by dinner fork. So the distal end of the radius will be dorsally deviated backward, dorsally deviated. This is called the dinner fork deformity. There is a risk of, because the median nerve passes in the front here, so there is a risk of the median nerve compression and having compartment syndrome later on, or something called the Krebs chronic regional pain syndrome. Chronic regional pain syndrome. So your treatment is basically analgesia, do reduction, and then immobilization in the back slab or plaster of Paris. And then there is some kind of indication for surgical treatment. We're not going to discuss this. It's very specialized for the orthopedic. So if it's non-displaced, you can do a resist flap. If it's displaced, young patient, you can do closed reduction back slab. Old patient, closed reduction plaster of Paris. If it's intra-articular, you can do open reduction, internal fixation. However, this is not always the case. Sometimes it's displaced with certain degree of dislocation. Okay, so or mean certain degree of. So basically, if you want to know it, if there is dorsal angulation more than 23 degree, you need to do open reduction, internal fixation. If there is loss of something called the ulnar variance. So basically, if you look here, this is your ulna, which is slightly higher than your radius. If this difference, if this step is lost, you will need to do surgery as well for open reduction, internal fixation. But I think for PLAB level, this is not really needed. So just know it, non-displaced, rest slab, displaced, closed reduction, or plaster of Paris or back slab, depending on the age. And if it's intra-articular, you do open reduction, internal fixation. A Smith fracture is the complete opposite of the Cool's fracture. So here, outstretched hand is not outstretched hand, it's basically on the other side when you fell on the dorsum of your hand. So known as reverse Cool's fracture. So it's the complete opposite. Distal radius with anterior displacement, and instead of posterior displacement, is anterior. And the distal fracture called garden spade deformity instead of dinner fork deformity. Okay, there is radial head and neck injury. So swelling over the lateral elbow and limited range of motion in this part, tenderness at the radial tunnel, which is basically the radial tunnel is where the radial nerve passes, and pain when the fingers are extended against resistance. The radial head fracture, head is big and common in adults, and radial neck fractures, neck is small, so common in children. So the head is common in adults, the neck is common in children, and this is just to remind you, all right? So this is the forearm fractures. We have here as well something called humeral fracture. So basically the humerus is formed of, so if this is your humerus, all right? So it's basically formed of a head, a neck, and you also have the shaft. So, and this is the condyles. So medial condyle and lateral condyle, and this is the supracondylar area. So this is your shaft, and this is your head and neck, and also the supracondylar area. So the fractures that can happen in the humerus are basically the supracondylar fracture. And I always call this is pediatric fractures. Most of the time happen in the pediatric patients. rather than adults. So it's more common in a childhood, and peak in is 5 to 7 years. Mechanism is hyperextension injury, and there is posterior or posterolateral displacement that might lead to injury or entrapment of the brachial artery. So keep an eye on that. It might lead to injury of the radial nerve or anterior interosseous nerve, which is a branch from the ulnar nerve. All right. So this is basically the supracondylar fracture. It happens in the children, more common in 5 to 7 years. The most important bit here, there's a very high risk of injury to the radial artery. So you will need to do immediate reduction for this patient, even before sending them to get a pre-X-ray, okay? The humeral neck fracture. So this is the neck of the humerus. There is something called, this is the anatomical neck, and this is the surgical neck of the humerus. So when we say neck fracture, humerus neck fracture, we mean that it is the surgical neck, all right? So at the surgical neck, you have a nerve and an artery. The circumflex artery passes, which is the anterior and posterior circumflex artery, and you have an axillary nerve as well passing. So all of these structures are at risk of injury. So basically, the patient will be presented by obvious deformity in your looking, okay? And when you're trying to feel, it will be deformed, it will be slightly hot, very tender, and when you're trying to move, will be loss of the abduction, and you will know why now. A neurovascular bundle, you will assess for hematoma presence, because you have two important arteries in here, anterior and posterior circumflex artery, and most importantly, the axillary nerve. If it is injured, there will be loss of sensation over your deltoid muscle and the flattening of the deltoid muscles. The humeral shaft, there is a risk of injury of the radial nerve, which passes in this area, and this is why you will look for presence of the wrist drop and loss of sensation in the first whip, in the anatomical snuff box area. Right? Humeral injury, proximal humerus is an axillary nerve risk, shaft is a radial nerve risk, distal humerus is a medial nerve risk. However, the here is the brachial artery is at high risk, right? I hope this is clear. Any question, guys? Any question, everyone? All right, I'll take this to the now. So we have here torus vs Green's-Tech fracture. So this happens at very young age. So torus fracture is basically a longitudinal compression force without any angulation. So it's a longitudinal compression force without any angulation. So it's basically happen most of the time in the tibia in very young children. So it's just like you have done some compression on the bone without any kind of obvious fracture. However, we call it torus fracture or buccal fracture. What do we mean by that? But that is like a bucket fracture. So due to just compression on the bone, okay, so it will look like a bucket on an X-ray. Green's-Tech fracture is basically an angulation force without interruption of the cortex, and this is commonest site for this fracture, for not a torus in here, for Green's-Tech fracture is the distal radius, right? Distal radius for ulna. So again, if you hear, this is torus fracture, is basically a bit of bulge on both sides due to compression. So the compression force was just like that, right? So it leads to some kind of bulge from the cortex, but this is not a proper fracture. But here is like a little bit of interruption of the cortex, but just one-sided, so the other cortex is okay, and it is bent now. So this is called green stack fracture, and both are very common in children. The fracture, toddler fracture, or spiral fracture, and always remember the toddler is TPL. Okay, most of the time it is TPL, or to be honest, it's all times TPL. The classical toddler fracture include the shaft of the tibia with severe pain and tenderness on the shin of the tibia. Usually it occurs in a child aged 9 months to 3 years, and the child falls on one leg flexed with twisted injury. So there is some kind of, twist in the area, but there is no interruption of the cortex. It's very difficult to diagnose it with a chest with an X-ray, but there is high suspicion if it's happening in a child presented with tibial pain after a twisting injury. So non-accidental toddler fracture is most of the time non-accidental because, if you have like an abuser father or something, will tend to twist their children's legs. It's common due to spiral fracture, and it's common in early walking years when the child twists the leg while running. That spiral fracture of the humerus, again, it's due to twisting injury. All right, so always have high suspicion of non-accidental injury in those patients. Do you guys want to break for 5 minutes? Guys, do you want to break for 5 minutes?
Yes, please.
Okay, so let's go for a break for 5 minutes, and then I'll see you in 5 minutes. All right. Hello again, everyone. It's Abdullah here. So yeah, let's carry on with the orthopedic. We still have loads to do. Where are we now? Yeah, we still have quite lots of things. So anyways, we're going to talk about the neck of femur fracture. This is basically in the UK, this is the commonest fracture, and it usually happens in old ages. And there are multiple different types of the neck of femur fracture. So it's either, the main classification is either intracapsular or extracapsular. And the second thing that you need to say, is it displaced or non-displaced? This is the NICE guidelines differentiation, and it differs in the management, okay? Non-displaced. So fractures, so usually it's a fall into the hip, usually an old patient, osteoporotic, sudden inability to weight bear, unable to weight bear on the side, pain in the knee, and again, the most important thing is the leg is shortened, externally rotated, and there is tenderness over the hip joint. So your examination, again, following the look, the feel, and move, and neurovascular bundle, and your management. So it's always in any hospital in the UK, there is something called National Hip Foundation, something, an HFD, that is responsible for making a pro forma. So for any neck of femur patient who's presented to A&E, you need to get them all the bloods done, you need to give them IV fluids, and you will need to give them IV analgesia, and give them the fascia iliaca block. This is very important, and get them basically ready for surgery by taking the group and screen and consenting them for surgery, which could be either total hip replacement, hemiarthroplasty, or ORIF, okay? And also counseling them about the risks and benefits of surgery and so on. So what is the complication? So as I mentioned earlier, the options of the treatment is either total hip replacement or hemiarthroplasty, which is half hip replacement, hemiarthroplasty, or over-reduction internal fixation using either dynamic hip screw or intramedullary nail, IM nail, okay? These are the options. So if it's an intracapsular, most of the time you will do an ORF, depending on the patient age. If it's an extracapsular, you can do replacement, all right? So what are the complications of hip replacement surgery? For any patient with hip replacement, they are at higher risk of having blood clot, DVT. This is why all the patients need to be on dalteparin, which is an anticoagulant medication to prevent that. There is loosening of the joint, probability of hip dislocation, and altered leg length. There is always a risk of ±5 centimeter difference between both thighs, okay? And this remains accepted. So this is the neck of femur fracture, the commonest fracture, generally the management of it, and then we can carry on. There's something called tennis elbow and something called golfer's elbow, okay? So tennis elbow, imagine the repetitive movement that you're making while you're playing tennis, and imagine the repetitive movement that you're doing while playing golf. So the movement is basically, in the tennis, you do like that. So your hand is always, your elbow is always coming to the outside, okay? So you're making pressure on the common flexor origin on the lateral epicondyle, because you're always like moving your hand like that while you're playing. So the extensor origin would be affected. So there is higher risk of affecting your extensor in this part. So again, it's exactly like tenosynovitis, which we mentioned early. So it's inflammatory process. So it's just pain management, okay? For golfer's elbow, it's the opposite. You move your hand to the inside while you're playing golf. So you're affecting the common flexor origin. So again, the treatment is just painkillers. The fat embolism, it usually happens with neck of femur fracture patients, specifically long bones fracture or pelvic fractures. Patient will present with some neurological and some petechial rash all over the body and hypoxemia. Because basically the fat that is coming from the inside of the bone will start to be transferred to the blood and goes all the way up to be transferred over the body. It will come to the skin, to the brain, to the lung, and will present you with hypoxemia, neurological symptoms, and petechial rash. Supraspinatus tendinitis. What is the supraspinatus? It is a muscle. So if you have here, if this is the scapular spine, and this is the scapula basically, like that. If that's your scapula, it doesn't look very nice. But if this is your scapula, so there is a muscle in here called the supraspinatus, and it is usually attached to the supraspinous area and the humerus, okay, the superior part of the head of the humerus. So sometimes it happens with sports like swimming and volleyball and tennis as well. There will be very pain while you're trying to do abduction to your shoulder or raise your hand above than 60 degrees, maybe while you're raising your hand above your head. There's something called Baker's cyst or popliteal cyst. This is most common site of Baker's cyst in the popliteal fossa, present with soft swelling on the posterior to the knee that is painless. However, it can present with acute symptoms due to Baker's cyst rupture, will be very painful. There is something called Fokker sign. It is when the cyst feels tense and full knee extension and softens when the knee flexes, all right? Diagnosis can be made by doing an ultrasound and commonly associated with osteoarthritis. And you can do it by surgical treatment by just taking it out or removing the cyst. All right. So we discussed here the other conditions. We discussed the neck of femur fracture, and we mentioned the treatment and the protocol for its managing in the UK according to the NICE guidelines. And then we mentioned the tennis elbow and its complete opposite, which is the golfer's elbow, fat embolism, supraspinatus tendinitis, and Baker's cyst. Ultrasound is diagnostic for Baker's cyst. Commonest site is popliteal fossa, and osteoarthritis is common. Surgical treatment is the best. Paget's disease is, or something called osteitis deformans. So there is an increase in bone turnover, which means the bone forms and disappear quite quickly. There is increased bone resorption by osteoclast and bone formation by osteoblast. So basically your bones are changing very quickly. And the new bone structure is weaker, bulkier, less compact, and more vascular. And this is basically the symptom that what will lead to the symptom that you will have. So you're at higher risk of having fracture because your bone is weaker and less compact and bulkier. It is vascular, so it will cause you very, very severe headache, okay? And it might also cause you the loss of hearing as well, deafness and tinnitus, okay? So it might be asymptomatic with just increased alkaline phosphatase and appearance of X-ray. Most of the time, it might be bone deformity. There is something called saproptopia, which is bowing of your tibia, just like this one, all right? So it's called saproptopia. And or bossing of the skull or kyphosis might lead to some pathological fractures, deafness and tinnitus, as you mentioned, and high output cardiac failure due to increase of this is basically increase in the hemodynamic circulation. X-ray is diagnostic. Alkaline phosphatase is high in all the patient. Serum calcium and parathyroid hormone levels are usually normal, but immobilization may lead to hypercalcemia. Management is giving alendronic acid or bisphosphonate. Note, patient with Paget's disease may notice is getting smaller due to sclerotic lesions. Osteosarcoma is a very high risk in patients with Paget's disease, and lytic lesions usually appear in multiple myeloma or something called punched out lesions. So the difference between osteoporosis, Paget's, and osteomalacia is the alkaline phosphatase. Alkaline phosphatase is high comparing with osteoporosis and osteomalacia. Serum phosphate is normal in Paget's, but low in osteomalacia and low in calcium, because we mentioned that malacia is problem with mineralization. So you have low calcium and low phosphate, but it's normal in Paget. That will make you differentiate between all the diseases, right? So this is basically Paget's disease. It's an interesting disease. Patient presented with high risk fractures, headache, tinnitus, and deafness, and high output cardiac failure, sometimes even anemia, right? So this is Paget's disease. We can also talk very quickly about the common tumors of the bone. Number one, osteosarcoma is most common primary bone tumor. It's common in children between 10 to 14 years. Arises often at the end of the bone where growth occur. So basically, I mean, here we'll mention the metaphysis is still on the old thing. So it's basically the distal part of the bone. So the older classification, so this is, if this is the diaphysis, there is a growth plate in here, and this is the epiphysis, and there's a growth plate in here, and this is the metaphysis, all right? So this is basically the older classification. So it's commonest on the metaphysis and more common in males. Lower end of femur and upper end of tibia is the commonest locations. And intermittent unilateral bone pain, worse at night, and X-ray will show something called sunburst or lytic lesion present, very raised alkaline phosphatase, sudden unexplained fracture in a very younger child, 10 to 14 years. You can do local excision or chemotherapy. So if you look here, this is the sunburst osteosarcoma. And we explained earlier that osteosarcoma is also common in Paget's disease, right? So this is the sunburst lesion osteosarcoma. Well, number two is Ewing sarcoma. So usually patient presented with systemic symptoms like fever and weight loss and malaise, adolescents from 5 to 15 years, and affect mainly the diaphysis, which is the bone shaft. So if you look here, again, this is the older classification. So diaphysis is just right there. So here, this part is the metaphysis, and just above it is the epiphysis. This part is the metaphysis, and just below it is the epiphysis. So epiphysis is basically closer to the joint. And here, epiphysis is closer to the joint. And then the metaphysis is just between the epiphysis and the diaphysis. But there is nothing called metaphysis now. It's basically the called the physis, which is the growth plate. Anyways, some X-ray lytic lesion present, or something called onion skinning. If you look here, so this looks like the skin of the onions. And there's something called giant cell tumor or osteoclastoma that occurs in the epiphysis, osteosarcoma in the metaphysis, Ewing sarcoma in the diaphysis, right? There's something called osteosteoma. It's one of the benign bone tumors developed in long bones, happen in femur and tibia. It's usually relieved by NSAID, so it's a tumor, but NSAID is very effective in its treatment and usually affected children, usually less than 1 centimeter in diameter. So pain in the lump and popcorn calcification, this is called chondrosarcoma. Well, before we move on, do you have questions? All right. Septic arthritis, this is one of the commonest things that happen in older people. Before I mention anything, I'll tell you the story. It's usually a 60-year or 60-plus-year female patient presented you with fever and feeling very unwell. Her knee joint, which is the commonest joint, is a swollen, red, hot, tender, and your A&E colleagues have done some aspiration of the synovial fluid and it was full of pus. They sent it to the lab and they started the patient with antibiotic. I'm asking you to review the patient. All right. It would be ideal if you have this scenario with A&E people, but this is not always the case. Cocker criteria. So non-weight bearing, the patient cannot weight weight bear, and temperature is less than 38.5, ESR more than 40, white blood cells more than 12,000. This is the risk of osteoarthritis. Acute hip pain plus fever, septic arthritis, or transient synovitis. All right. So septic arthritis is a very important diagnosis, a very important thing to know. And this is you're going to treat it. If you remember how we discussed the sepsis sex protocol, this is the treatment for septic arthritis. There's something called transient synovitis. It's acute hip pain, less than 48 hours, occurs viral infection, most commonly happen in the hip joint, and follow the upper respiratory tract infection, the pain on weight bearing, but not at rest. There's something called juvenile idiopathic arthritis occurring in someone less than 16 years old and lasts for more than 3 months. Present of systemic onset, fever can occur at the same time as well, and there is a blanching rash, so difference here, this happens in young people. So this is a very good classification. And anyone who's below than 3 years old, think of DDH, toddler fracture, septic arthritis. From 3 to 9 years, think of transient synovitis or Perth disease, but above than 9 years, think of SOFI, slipped upper femoral epiphysis. This is a very good and important classification for your exam, and they won't trick you. They won't bring like a DDH in a 21-year-old man. Is it possible to happen? Yes, it is. It can happen, but still it's less likely that it will come in the exam. That's your knee joint. So this is the femur, and you have here the condyles on both sides, and this is the tibia, and you have here the menisci. So this is the medial meniscus, and that's the lateral meniscus. You have ligaments, the anterior cruciate ligament and the posterior cruciate ligament. You have also some other ligaments here. This is the lateral collateral ligament, and this is the medial collateral ligament. And I think it's very relevant now to know because we are going to examine them in a bit more detail. So again, so this is the menisci, and this is the anterior cruciate, posterior cruciate, and there is something called the medial meniscus, the medial collateral ligament and lateral collateral ligament. Okay, medial collateral ligament injury. So if this is injured, so it's usually happen with, so it's in the medial side. So when you twist your knee to the other side, the injury, I mean, this one will be very stretched and it will come apart. So direct blow to the lateral side, despite it's in the medial, when you hit someone here, okay, the knee will be twisted like that, like this and like this, and then it will be injured. Occurs along with meniscal tear as well. So lateral collateral ligament injury, it will be the opposite. If you kick someone on the medial side, this will be stretched and will cause some injury. There's something called anterior cruciate ligament and posterior cruciate ligament. If there is any deceleration injury, somebody was running and suddenly stopped. When the athletic lands on the leg quickly on the opposite direction, the ACL or anterior cruciate ligament will tear, okay? And they will typically be presented to you by hearing a pop sound, okay? Followed by immediate swelling. The posterior cruciate ligament, it's on the other side. So it's a hyperflexion injury. Hyperflexion injury leads to injury of the posterior cruciate ligament. All right. Some meniscal tear. So as we mentioned earlier, we have two menisci, medial meniscus and lateral meniscus. The medial meniscus is the commonest, and it does have some reasons, because twisting or pivoting, the patient will again hear some popping sound. Usually this is associated with ACL injury, and the patient will have the difference in the swelling is delayed in meniscal tear. So in ACL, the knee will be immediately swollen, but in the meniscal tear, it will be slightly delayed. The patient will be presented to you by locked knee, but the patient will learn with time how to unlock their knee. The initial management is rest and give them medication, and later on you can do endoscopy, okay? Here, there is some tests, something called McMurray and Applis test. The best way to know about this, please watch the 2 videos we have involved. It's part of the course. Just watch the videos and you will understand the exact examination. Okay, so any questions so far, guys? I know I might be going a little bit fast, but as we mentioned earlier, this is a very long session, so we need to get it done as much as we can. Any questions?
Yes, I have a question.
Of course.
With the medial collateral ligaments injury, which meniscus is usually injured here?
Very good question. So generally, the medial meniscus is 90% of the time. Medial meniscus is 90% of the time injured. Okay, so lateral meniscus is very less likely. And again, the lateral collateral ligament injury is commoner than the medial collateral ligament. Okay, so if the medial collateral ligament is injured, if you imagine it, so you kicked someone here, so the fibula will be coming all this way and pressing here. So basically, the lateral meniscus will be at higher risk of injury, if that makes sense.
Yes, that does make sense.
But I mean, it's very less likely that will happen after all, but usually it is related to it. But if you think about it again, if you have like a bone model, when you look at it, you will find that the medial condyle is slightly lower than the lateral condyle, okay? So we mentioned earlier that the ACL injury, is also related to meniscal tear, right? Remember that?
Yes.
So again, it's because the ACL will be basically like extension injury. So the medial meniscus will be at higher risk of injury again because the medial condyle is slightly lower than lateral condyle, if that makes sense. Okay, so again, ACL injury, it happens with deceleration injury. So ACL tears usually is a stem where the foot is fixed in the ground. So it's basically like hyperextension injury again, followed by immediate swelling. This is the key part, immediate swelling. For meniscal tear, it's delayed swelling, all right? Delayed swelling. So again, differentiate. So PCL is hyperflexion. What about ACL? Is basically hyperextension, or you can't really get hyperextension, or basically it's an extension injury. Okay, so PCL is a hyperflexion. But again, this is 10%. ACL is 90% of the injuries. Medial meniscus is 90%. Lateral meniscus is 10%. So again, most common meniscus to be injured is the medial meniscus, twisting or pivoting or popping sensation, often associated with ACL injury. And we mentioned the reason why, because the medial condyle is slightly lower than the lateral condyle. So when you have a hyperextension injury, this one is more likely to press down on the meniscus. Please watch the 2 videos. All right. So sciatic picture. So what is sciatica? Is basically, so if we have, this is a vertebra, and this is another vertebra. Between them, there is a disc. And here is the spinous process, and here is the spinous process as well. And passing from the middle is your spinal cord, right? And getting all the way down here, you have a spinal nerve roots on both sides. So if this disc, which is formed of two areas, so the disc is usually like that. If you look from up, is formed of two gelatinous material. The inner area is called nucleus pulposus. The outer area is called annulus fibrosus. So what will happen here if you have a disc? There is weakness in the pulposus. Weakness in the fibrosus, and the pulposus starts to protrude. So again, which part is protruding? Is the pulposus is protruding, right? The pulposus is protruding. So the L2 disc is very uncommon. Think about the dermatomes and the myotomes, and think about the reflexes. Remember the ankle reflex and the knee reflex. It was S1, 2, 3, 4, right? Remember that, and remember your dermatomes, the outer are odds and the inner are even, right? Okay, so let's start from actually S1. So S1, there'll be loss of sensation on the outer aspect of your foot, the lateral aspect of your foot. Remember, it's one of the odds, right? Weakness in your plantar flexion of the foot, absent or decreased ankle reflex. Remember, it's 1, 2, 3, 4, right? This is how you remember it. L5. So basically, L5 is one of the odds. So it will be loss of sensation on the dorsum of the foot and the outer surface of the leg, all right? Weakness in ankle dorsiflexion, reflexes are intact because it's 1, 2, 3, 4. So 5 is not involved. And 4, there'll be sensory loss on front of the knee, anterior aspect of the knee, and the medial side of the leg, right? And it's the 4. So 1, 2, 3, 4. So the knee jerk will be decreased. And there is something called positive femoral stretch test. Again, you can always watch the video about the femoral stretch test. You're basically doing a stretching of the leg in extended position backward. L3, what about the knee jerk? Would be decreased. And positive femoral stretch test, and L3, it's one of the odds over anterior thigh and outer surface of the thigh as well. L2, anterior thigh pain, and positive femoral stretch test. Okay, so tests for sciatica, there is something called positive femoral stretch test. It's just right there. You're stretching. It should be a little bit extended on the other direction. It will cause pain on the femoral nerve if it's all T3 and 4, which is the femoral nerve coming from. Sciatic nerve is a straight leg raising test because the sciatic nerve is backward. So it's basically sciatic nerve stretching test. Cause of sciatica: disc prolapse, spondyloarthritis, spinal injury, metastatic spinal cord, and cancer. Gold standard for diagnosing is an MRI, and again, management of neuropathic pain is usually by amitriptyline. Can someone remind me? We know here that the amitriptyline and pregabalin on the first line, and trigeminal neuralgia, which painkiller will you use? And trigeminal neuralgia. Can somebody remind me? In trigeminal neuralgia, which painkiller would you use? What is the most effective painkiller in trigeminal neuralgia? Can anybody say? Okay, so carbamazepine is the best painkiller, and duloxetine is the best painkiller in peripheral neuropathy. Anyways, osteomyelitis, from the name, it's infection to the bone and the muscles around it. osteomyelitis, right? Infection of the bone marrow and may spread to the bone called periosteum. It can be categorized as either acute hematogenous secondary infection or direct inoculation from surgery. Most common site, distal femur, and proximal tibia, and it affects the calculus bone as well in adults. When dead bone becomes detached from healthy bone, it's known as sequestrum, and the last sequestrum that remains in situ acts as a focus. The causative organism here, most of the times it's Staph aureus. There are some risk factors, which includes if you have like a tissue that cannot fight against bacteria, it's diabetic due to deposition of glucose, it's due to decrease of the blood supply, or due to impaired immunity, or probably due to sickle cell disease, surgical prosthesis, and open fractures as well. All of these are risk factors for osteomyelitis. This is some sort of a sepsis. You will need to do full screen, which is basically FBC, UNA, CRP, blood cultures. You can take a bone biopsy from the patient, which is the gold standard for diagnosis. You can do an MRI, and sometimes plain X-ray could be diagnostic, but MRI is very diagnostic. Treatment, since we mentioned the commonest organism is Staph aureus, so flucloxacillin is the first line of treatment. You can add fucosylic acid and rifampicin for the initial 2 weeks. If the patient is penicillin allergic, you can give clindamycin instead. If it's MSRA, which is if it's MRCS, which is methicillin-resistant Staph aureus, you can give vancomycin. Surgical debridement remains as one of the treatment options as well, and analgesia. Complications, septic arthritis, patient might go into sepsis, fractures, deformity, and the chronic osteomyelitis. So basically, osteomyelitis is an infection to the bone, marrow, and the surrounding soft tissue. The source, like any other source of bacteria all over the body, it could be direct during surgery. It could be hematogenous spread, which happens from like patient had already sepsis and the infection has been transferred to their bone. And it will lead to the commonest organism here is most of the time Staph aureus, and the risk factors, patient who are at higher risk of getting infection, immunocompromised patient, HIV patients, surgical patients, patients with open fractures, diabetic, vascular injury or vascular disease, or impaired immunity, like we mentioned, like AIDS patients, and also sickle cell disease. Investigations, it's a septic patient, get all the bloods done with all the blood cultures. You can take biopsy, you can do an MRI and an X-ray as well, give your patient the septic sepsis protocol, give them antibiotic. The best antibiotic to use, the flucloxacillin, because the commonest organism is Staph aureus. You can do surgical debridement for the patient as well, and you're giving them analgesia. Surgical treatment remains as one of the good lines to treat. Okay, acute compartment syndrome. This is something that is very important. The typical scenario, which I've seen multiple times before, is having a patient with very bad fracture, most time in the tibia or in the femur. And they've gone into the ward at night, and then the nurse will be calling you, telling you, I have a patient in here with very severe pain in his leg. You go and examine the patient, you'll find that they have a cast. The pain is very severe, and they can't tolerate it. You examine the leg, there'll be slightly diminished loss of sensation. The pain is out of proportion to the finding that you can find, the finding on your clinical examination. Sometimes, which is very late, they are pulseless, and sometimes they are paralyzed, which again, very late. So, what you need to do now, make your patient relaxed, give them some painkillers, and do all the blood for them, and arrange the patient for theater to be taken within 30 minutes maximum, to be taken to theater to have something called fasciotomy. Okay, this is limb saving procedure that needs to be done within an hour. I mean, it should not take more than 1 hour to get the surgery done. It's a painful and potentially serious condition, which is caused by bleeding or swelling inside a closed compartment. Causes severe high blood pressure severe high pressure. I wouldn't say blood pressure. Severe high pressure in the compartment, insufficient blood supply to the tissue and muscles and nerves, and this might lead to necrosis. Happens suddenly, usually after a fracture of a severe injury, and if left untreated, it might lead to permanent muscle and nerve damage, broken bone, plaster cast, and burns and surgery. Features pain, pallor, paresthesia, pulses, paralysis, like we mentioned, emergency fasciotomy to cut the fascia between the muscles to give it a bit of space. Rotator cuff tear. So the rotator cuff are 4 muscles that, if you remember my diagram for the scapula, so this is the spine, that's the scapula right here. So here you have a muscle called supraspinatus, right? And here you have a muscle called infraspinatus. You have here another muscle called teres minor. And on the other side, there is something called subscapularis. These are called the rotator cuff muscle. They might have a tear, usually follow minor trauma, and there is weakness, is a very common feature. Ultrasound is diagnostic. Subacromial impingement. It's a small bursa all over the acromion. Arthritis and bony spurs and bursitis might cause impingement. Humeral head cannot depress enough to slide under the acromion, and the arm is abducted. The patient will be in severe pain. Calcific tendinitis. The common scenario here is female patient after mastectomy presented to you with a very frozen shoulder. So this is basically the frozen shoulder due to calcification in the tendon in this area. The management is pain relief, physiotherapy, steroid injection could be one of the options as well. Surgery is rare and it's the last enough to treat. So as you look here, this is the supraspinatus, and this is the infraspinatus, and this is the teres minor, and then the other side, this is the subscapularis muscle, and these are called the rotator cuff muscles. Shoulder dislocation. So basically in the shoulder, you have here, this is the glenoid of the scapula, and here you have the head of the humerus, right? So dislocation is one of 2 types, either anterior dislocation, which is the commonest, 90% of the presentation, and posterior dislocation, which is less common, only 10% of the presentation, and usually happen with electrical shock or epilepsy. So it's E&E, okay? So anterior dislocation typically present in young males, contact sports, and the repeated dislocation happen in Ehlers-Danlos syndrome, all right, which is laxity of the joints. Well, presentation, you have the patient hold their arm like they're holding a baby, loss of shoulder contour, and the anterior pulse, and would be a space in this area as well. There is risk of nerve damage, and rotator cuff tear or rotator cuff injury is at high risk as well. You do an X-ray with something called Y view or scapula view, and the treatment here is basically relocation. I would advise that you watch the Cocker method for relocation on the YouTube, which is, the link is attached. You need to give your patient some good analgesia and some muscle relaxants, and do the simple reduction and support the arm in something called polysling or broad arm sling. Posterior dislocation is very less likely. It doesn't usually happen. There is something called adhesive capsulitis or frozen shoulder or calcific tendinitis, which you mentioned early. So thickening and contraction of the glenohumeral joint capsule and leads to adhesions, usually called the frozen shoulder syndrome, and happens either in elderly or patient post-operative, specifically in patients with breast cancer. It happens spontaneously and usually happen as well following rotator cuff injury, diabetic and thyroid disease as well. Gradual pain and stiffness in this area. There is also restriction in the shoulder movements and both active and passive, and inability to sleep can be affected. Investigation, diagnosis, clinical diagnosis, X-ray, usually normal. You give them analgesia, you give them a steroid injection, physiotherapy, and capsular distension, which can happen by injecting fluids inside the joint. Well, we have multiple sling types. There is something called the broad arm sling, and this is the one that you can see here. And the high arm sling, that's the one. And the collar and cuff is, oh, sorry. This is the collar and cuff, all right? This is the collar and cuff. And there is something called high arm sling, which is basically like this one, all right? So collar and cuff, fracture of the clavicle, because you need to relax the, or get the clavicle down by weight. So you need to elevate this part. And supracondylar fracture or radial and head and neck fracture, okay? There is Achilles tendon rupture as well. I'm sorry, guys, it's a very, very long session, but we are on the last page. So Achilles tendon rupture, there is history of repetitive jumping motion. It usually happens when the patient is starting to run very quickly. There will be a snap. There's something called cement triad. So affected leg rests in a more dorsiflected position. There is palpable gap at the heel. There is no plantar flexion on calf squeeze, all right? This is called Simmons triad. Difficulty in walking, and there is plantar flexing against resistance. You do an X-ray, you will see calcaneal avulsion, usually happens, and prophylactic DVT is very important. They need to take that for 6 weeks. They're high risk of having DVT. You can treat it by costing or sometimes surgery is an option as well. Sprain injury, and this is the price. You need to protect it, have some rest, have some ice, compression and elevation, usually happen in the ankle tendons after running very quickly. So we've reached the notes. So this was the orthopedic session. So now, guys, would you like to have some questions as well? Guys, I do have questions for you. Would you like to have them?
Okay, I think it's just me, but I don't have any questions.
Oh, wow. Yeah, I mean, I know it's a very long session. It's very unfair to have this as one session, but I'm not the organizer. I'm the one who explains. Anyways, well, would you like to do some questions or?
Oh, yes, I would like to.
Okay, let's do some questions then. All right, we're not gonna do long. We're gonna do just a few questions, because I mean, just you anyway. So do you want to read?
Okay. Okay, a woman comes with an ulcerated lesion 3 centimeters in the labia majorum. What is the lymphatic drainage of this area? Okay, so that will be, I think that will be B.
Superficial inguinal lymph nodes. Excellent, well done. So yeah, if you remember the table that we have explained, where does everything go, the whole thing. Yeah. Anyways, next question.
Okay.
We have 63, female patient, high BMI, pigmentation in her legs. Examination, you found dilated veins, could be seen on the lateral side of her ankle. Which of the following is involved? We didn't explain the veins of the lower limb, but that's the question is now. So you have 2 veins in the lower limb. One is the long saphenous vein, and the other one is the short saphenous vein. So the long saphenous vein is on the medial side, and the short saphenous vein is on the lateral side. So this is basically the short saphenous vein. All right. Next.
Okay.
40-year female patient collapsed and died. She's very young. Post-mortem autopsy was found there is a bleed from a perianeurysm in circular fillers. In which space did the bleeding occur? We explained that in neurology, right?
Yes.
So where are the blood vessels in the brain? All the blood vessels are in just one space. You only have 2 spaces in the brain. It's either the subdural space or the subarachnoid space, right? Extradural is not actually a space, it's a potential space. So there is no space that is called extradural. It just happens when you have a bleeding, okay? Obviously the ventricles, it's all full of CSF. So it's
Yes.
either the subdural or subarachnoid. Which one do you think?
In this, with the berry aneurysm, I think it would be is it the subdural?
No, it's not a subdural. It's definitely a
It's
subarachnoid.
subarachnoid.
Because yeah, when you
Subarachnoid.
have a subarachnoid hemorrhage, you always think of aneurysm. So
Yeah.
the hemorrhage happened in subarachnoid space because all the blood vessels are in subarachnoid space, right? Next question. L1 level. What is the most appropriate landmark at L1 level? Remember that big table, the first thing we explained today?
Yes.
It's called Addisonian plane or transpyloric plane at the level of the pylorus, right?
I noticed.
Artery runs on the anterior interventricular groove. So this is the blood supply of the heart, which we did not explain today, but that's something that we're expecting you to read as well.
I know this is. Is it the circumflex artery?
You think the circumflex is in the anterior interventricular groove, or
Yeah.
just goes backward from the left side, right?
Yeah.
In the posterior groove, right?
Okay.
So it's the anterior interventricular, it's the biggest artery in the anterior part, so it's going to be the lat. Okay, left anterior descending artery. Okay, do you want to read that?
Okay, a 73-year-old woman with rheumatoid arthritis is unable to extend her fingers of the right hand at the MCP joint and the IP joints following a fall. What is the single most likely tendon that is damaged? She's unable to extend. So if she's unable to extend her fingers, it would be if she's unable to extend, then right. If she's unable to extend, there will be a problem with the flexor.
So it's in all her fingers. No, it's not flexor because she's unable to extend. She can't extend. So her extensor digitorum is affected, right?
Okay.
Yeah.
Okay. Can you just, okay, yeah, that's fine.
Yeah, you can read it. So she can't extend. What's difficult about that? She can't extend. So that means the extensors are not working. So we're thinking about it. So the flexor is very less likely. So if the flexor digitorum is affected, she won't be able to flex. That's why it's called the flexor. So the question is it extensor carpi radialis or ulnaris or digitorum or indices? In the indices one, we'll be talking about the index finger, right? And the carpi radialis and carpi ulnaris, you'll be talking about something about the wrist as well, but the wrist joint. But here we're talking about the digits. So you have the 4 digits. You said the metacarpophalangeal joint and the interphalangeal joint are not working. Joints, so it's an S as well. So that means the extensor digitorum is not working. Yeah.
Okay.
Let me give you some of the orthopedic instead of all in anatomy.
Okay.
All right. Let's go through. Yeah.
Okay.
Man, emergency was fracture of head, is deaf, and bilateral pedal edema, single most probable diagnosis.
Would be Paget's disease.
Yeah, excellent. Paget's disease. Next one. '63 osteoporotic, sudden fall, outstretched hand, X-ray of fractured distal radius. Distal radius is one of two things. Is it Cooley's or Smith fracture, right?
Yes.
With back backward shift of distal fragment. What is the single most likely diagnosis?
It'll be
Probable
the
deformity,
dinner
sorry. Deniform deformity. What is the other one called?
The green stick.
No, it's not green stick. It's called Gardner's spade deformity for a Smith fracture.
Okay.
Yeah.
Yeah.
Next one.
Hello.
67 collapses, not
Sorry, I can't see your screen.
able to move.
Oh, the screen froze.
Did you hear me?
I'm not sure whose Wi-Fi it is, but on my side, your screen is frozen.
I think it's fine. And I'm giving you the questions. I have like 30 questions. It's I think I will send you all the questions.
Okay. Yeah, I think that would be best. And then if I have any questions, I can ask. Oh.
Hello, can you still hear me?
Yes, I can hear you now.
Hello? Hello? Yeah, it's fine. I think we'll stop for now because I think there is an issue with my connection. And I will send you the questions in the group.
Okay, and if I have any questions, I'll post them on the group.
Thank you.
Send them to you.
Have a good day.
Thank you. Thank you. You too.
Yeah, of course, just right. Thanks, bye.
Okay. Okay. Thank you.